All right, so here's the first slide. If you can do this, you'll do just fine. Okay, so this is what most people remember from first year biochemistry, and then you shut the book and hoped it would never come back again. So hopefully some of this will begin to make sense as we go through it and break it down into some better components than just being overwhelmed with a sea of metabolism. Now that you all are postprandial and breaking down all of your fats and carbs and proteins. So we're going to do an overview of different types of inborn errors of metabolism. We're going to review some specific metabolic disorders. We're going to discuss some of the management of inborn errors of metabolism and overview of newborn screening disorders. All right, so inborn errors of metabolism were first described by Sir Archibald Girard in 1908. Individually, they are rare. However, they account for about 20% of diseases in sick, full-term newborns. So when you get that sick newborn, this is one of the things that you should be thinking about. The first three things you should think about are what? Sepsis, sepsis, and sepsis. Okay, but you also have to remember that inborn errors of metabolism can present and look exactly the same way, so don't forget about them. They can have nonspecific presenting symptoms, but many are treatable with early recognition, so you could actually step in and save a baby's life. And many are more common in certain populations, so it's important to remember the ethnic backgrounds that are associated with certain types of metabolic conditions. The inheritance. Most have autosomal recessive, so if you have to guess, guess recessive. Most will not have a family history of the illness. The exceptions are mitochondrial disorders, and then the X-linked disorders. So memorize your X-linked disorders and then guess autosomal recessive for everything else. OTC deficiency, X-linked adrenoleukodystrophy, Hunter syndrome or MPS type 2, Lesch-Nyhan, and Menkes disease are common X-linked metabolic conditions. So categories. Ways to think about broadly about metabolic conditions. Problems of intoxication. These can be acute or progressive, and they're due to an accumulation of toxic compounds. You can have problems of energy metabolism. So the symptoms are not from having too much of something, but not having enough of something else. So you're not getting enough energy out of the system. And then you have problems of complex molecules. So either you have problems with synthesizing a complex molecule or breaking it down. And the symptoms for these are permanent and progressive. So we're going to start with disorders of intoxication. All right, so this is the infamous metabolic pathway. A has to be turned into B, which then has to be turned into C. If the enzyme that takes B to C doesn't work, A goes up and B goes up. This will then intoxicate the individual, and you'll get symptoms based on having too much of A and B. So diseases that fall into that category include amino acid problems like phenylketonuria or PKU, maple syrup urine disease, and tyrosinemia. Organic acidemias fall into this category like methylmalonic, propionic, and isovaleric. The urea cycle defects, OTC is in purple because it is X-linked. Citrullinemia, ASA or arginosuccinic aciduria, and then the other one they like to ask about is CPS1 or carboxyl phosphate synthetase deficiency. And then sugar intolerances, including galactosemia, and then hereditary fructose intolerance. So generally, the enzyme block is in protein degradation and disposal or in sugar breakdown. And it results in a buildup of keto acids or nitrogen, which is your ammonia. And these are the metabolites that cause the clinical problems. Anything that makes your catabolism cranked up or you increase your protein intake will make your symptoms worse. So if you're in a time of illness, you have a fever, you're going to have increased catabolism, you're going to see worsening of symptoms. So the hallmark for the presentation is a period of normalcy, and then you get sick. So you don't look ill at birth. You look like a perfectly happy, healthy newborn, and it may be hours to years before you start to show symptoms. So just because it's didn't happen in the first 24 to 48 doesn't exclude it from being a metabolic condition. If it happens in the first 24 to 48, then it's a little more helpful for you to think about. It can be an acute illness, or it can be an intermittent illness, and it may be insidious with developmental delay and mental retardation. And the classic for that is PKU, and that's why it started the newborn screening program, is because by the time you saw the problem, which was mental retardation and seizures, it was too late to do anything about it. But if you start the diet at the very beginning, you can avoid all of those problems. MMA, however, Methylmalonic Acidemia, presents with a ketotic metabolic acidosis and vomiting, so much more attention getting rather than being this insidious onset. So you can see abnormalities on screening tests. So you look at urine organic acids, plasma amino acids, plasma acylcarnitine profile, and then most states now have moved to expanded newborn screening. So not only are you getting PKU and hypothyroidism, but you're now getting this whole tandem mass spec of all of these compounds of your acylcarnitines and amino acids, which allows us to pick up a much broader range of inborn errors of metabolism from the time of birth. The abnormalities will be more striking if the patient is symptomatic. So if you have an ill child, you're going to start skewing those compounds even more. And some of the diseases you will actually normalize during periods of normalcy. So you may draw labs in clinic and it looks perfectly normal. We'll send people home with a prescription that the next time you go to the emergency room for a fever, have them draw these labs, hoping that we can see the body unmask its metabolic problem. Again, the goal is to identify the problem during an asymptomatic period, and the target time for identification is on newborn screening and should be done at 24 to 48 hours. Just as an aside, many of the hospitals I've been at will sort of drift off to after 24 hours means prior to discharge, which then can be 3 to 5 days if mom's had a C-section or any problems. It really does mean 24 to 48 hours. If you're waiting that long to do a newborn screen, you're missing an opportunity to get back early test results. The treatment is dietary restriction, so you want to remove the precursors that build up and poison the cell, because that one block is there, A and B is going up, so you want to decrease how much of A and B is going into the system. And you want to avoid any dietary compounds that cause problems. And you want to avoid catabolism when you can, because then you get some unrestricted protein breakdown just from your body. So we'll talk about PKU, which is an abnormal buildup of phenylalanine. So you go to see a new baby in clinic and was identified on newborn screening to have high Phe levels, and confirmatory testing was confirmatory for PKU, and the baby is growing well and developing well. When you're taking the family history, they mention a severely retarded older brother who has seizures and autistic features. And the brother was born in Russia. Test him and also confirms that he has untreated PKU. So remembering, PKU is one thing that is tested in all of our states and has been since the 60s, but that does not guarantee that when people come from overseas that country actually has a newborn screening program. It's becoming more of the standard, but, look back and check. So it's the most common disorder of amino acid metabolism and has about a 1 in 10,000 incident. The gene carrier frequency is about 1%, and it's more common in certain ethnic groups. It's about 1 in 4,000 in the Irish, and it's about 1 in 500,000 in African Americans. It is autosomal recessive. I like the pathway for PKU because phenylalanine is an essential amino acid. The only way you can get it is by eating it. You don't metabolize it or make it in your own body, and it goes from phenylalanine to tyrosine, so A to B. And the problem is with this enzyme, phenylalanine hydroxylase. So if it does not work, phenylalanine will go up and your tyrosine goes down. So on an amino acid profile, you've got A and B. You just have to know what A and B you're looking for. So these kids look normal at birth. Untreated, severe mental retardation with IQ of less than 30, and the damage is irreversible by 8 weeks of age. You can have seizures, autism, irritability, vomiting, eczema, decreased skin and hair pigmentation, and a musty odor, which is the phenylacetic acid. The goal of newborn screening is to start on treatment by at least 14 days of age. So you sort of have a little grace period in there to get the parents in and get people started on diet. So to make the diagnosis, you need an elevated plasma phenylalanine level, and the baby cannot be on TPN because that's going to skew what amino acids are going in. And then you have a low plasma tyrosine level. You also look in the urine, and you can find elevated levels of phenylalanine metabolites. And you should also look at tetrahydrobiopterin levels because you need that cofactor to make phenylalanine hydroxylase work. So if you have a deficiency of tetrahydrobiopterin, you'll look like you have PKU. And on newborn screening, they do tandem mass spec to do quantitative Phe levels. So it's not like the old Guthrie test, which were qualitative. These are actually quantitative numerical values of exactly how much is there. So you can also have PKU due to a deficiency of tetrahydrobiopterin, and about 2% of babies that have a hyper-Phe or an elevated phenylalanine level have a defect in one of the tetrahydrobiopterin enzymes. And these kids will have neurologic symptoms despite good dietary therapy because you need your tetrahydrobiopterin to run other enzymes as well. So you've got other enzymatic defects. So you treat with BH4, L-DOPA, and 5-hydroxytryptophan. And so here again is our pathway, and some people have problems in this resynthesis. And when that happens, and you have to look at other enzymatic pathways that's playing a part of. So we do a low Phe intake for life. It's about 40 mg per kg per day, and you use a phenylalanine-free formula, like phenyl-free. And what it does is give you all the rest of your amino acids back without giving you phenylalanine. We used to take kids off of diet when their, quote, their brain was done maturing at about age 8, and we were wrong. Your brain does not stop maturing. We now recommend that you stay on it for life. So it is a lifelong diet. We monitor their blood level and adjust the Phe level or their Phe intake accordingly. And again, back to this whole idea about birth defects, we need people on preconception dietary control. We actually need them to have a lower Phe level if you're planning on getting pregnant, because the placenta will concentrate the Phe about 2.5 times what the mom's blood level is. And so we see effects in about 80% of exposed fetuses, and that includes a small head, mental retardation, growth impairment, and congenital heart defects. All right, homocystinuria is an abnormal metabolism of methionine. Well, case presentation, 24-month-old male, noted to have a wide-based gait at 18 months of age, history of gross motor delays, but good fine motor skills. An MRI of the brain showed diffuse white matter abnormalities consistent with a dysmyelinating disorder. And he was referred to the neurologist for evaluation of possible metabolic brain disease causing ataxia. On the labs, we saw minor elevations in AST and ALT. The CK level was elevated at 410. Normal lactate to pyruvate ratio, and plasma amino acid showed a very high methionine at 859 with a normal of 53. Was also found to have an elevated homocysteine level. Total plasma homocysteine was about 170, and normal should be less than 10. So these are 10, 20, 50-fold higher levels. So homocystinuria is most commonly due to cystathione beta synthase deficiency. Will give you elevated homocysteine levels. The clinical features, again, that marfanoid habitus. So remember back to Marfans, this is the phenocopy, but this is the recessive rather than dominant Marfans. Developmental delays, has a downward displacement of the lens, so also has ectopia lentis. Marfans tends to displace upwards. And there's also an increased risk of thromboembolism. And we give them pyridoxine for the vitamin-responsive form. And we give them a diet that's low in methionine, and we supplement with L-cysteine, betaine, which increases your homocysteine metabolism to methionine, so it helps drive that system. Tyrosinemia type 1 is also autosomal recessive, and it presents with failure to thrive, liver failure, renal failure, and eventually liver cancer. The symptoms are caused by accumulation of succinyl acetone, which is one of the byproducts when you're starting to break down tyrosine. So the treatment is to block the step before the succinyl acetone is formed. You may not catch this on newborn screening, But tyrosine is not the problematic metabolite, and so it might not be elevated initially. It's the succinylacetone, and that's the pathognomonic compound for tyrosinemia type 1. We treat with a compound known as nitisinone, also known as NTBC, and we put them on a low tyrosine diet, and we have a greater than 90% survival rate. There still is a cancer risk, but at least we can get kids to being a much larger size before they need to have a liver transplant. So here's the pathway. We start at the top with phenylalanine, going to tyrosine, and so if this is blocked, this is where you've got PKU. Then you keep coming all the way down, and right here is where you have tyrosinemia type 1. And when you block this low down, then you start shunting over into succinylacetone. So now these two go up. And those are your toxic compounds, or these sideline products. So what we do then is we give NTBC, which knocks out this other enzyme. And so everything below that doesn't get made. So now you subsequently are going to kick up your tyrosine level. So we need to decrease how much tyrosine is in the diet. But now you're taking out that really bad compound, which is causing all the problems. So it took that away. All right, nonketotic hyperglycinemia is also known as glycine encephalopathy. This is a glycine problem, not a glucose problem. So it's nonketotic hyperglycinemia. It is autosomal recessive. The glycine accumulates in all tissues, and especially the brain. Presentation is in utero hiccups, and in the neonatal period, seizures and apnea that require intubation, and that's the classic presentation. You can have atypical presentations with seizures with a mild or severe course. And remember, glycine is one of your precursors for all of your neurotransmitters. So features of the classic disease: progressive lethargy, low tone, myoclonic jerks, frank seizures that often lead to apnea and death, and mental retardation that is profound in those that survive. The atypical forms have variable outcome, but almost all have some type of neurologic impairment. The diagnosis is by comparing your CSF and your plasma glycine levels, because you may have just mild elevations in glycine in your blood, but what is really striking is what it's doing in your CSF. All right, the urea cycle. Everybody remembers the urea cycle and loves it, right? Okay. Everybody's urea cycle is working very nicely right now because we've all had protein. So this is disorders of protein metabolism and nitrogen disposal. So we have 6 well-documented diseases. And the overall incidence for all of them combined is 1 in 8,500. Things that are common to all of them: high ammonia, increased glutamine on your serum amino acids. You're not making ketones, so you don't have a ketoacidosis, but you do have a respiratory alkalosis in mild or no liver dysfunction. You need to check your citrulline on your serum amino acids and your urine orotic acid. Those are the 2 compounds in your A to B to C that help you determine where that block is. All right, here's the pathway. Going round and round we go. So NAGS, CPS1, OTC, arginosuccinic synthase, arginosuccinic lyase, and arginase, and we've completed the whole cycle going around. So the compounds we need: orotic acid, citrulline. We usually don't get an arginosuccinate on our plasma amino acids, but you can get an arginine. So if you know those, which ones are up and which one are down, you'll know where A, B, and C are. So the clinical findings for urea cycle defects are usually due to astrocyte swelling, and that's due to an increase in ammonia and glutamine. It'll give you vomiting and poor feeding and brain edema. You usually don't start seeing lethargy and confusion until your ammonia gets above 100. We often get phone calls about the ammonia level is 45. Yes, and I bet you it's walked around the hospital for about 3 hours rather than going down on ice. So really, for the ammonia to really be causing a problem, you need to get up over 100. That's the attention getter. You then, as you keep climbing, go into a coma, and then you herniate your brain. So you go to see a 48-hour little newborn boy. He was discharged home at 12 hours of life. He was in normal term pregnancy without any problems, and it's the parent's third child. They were concerned because he ate well for the first day, but they can't wake him to eat. He's breathing fast, he's lethargic, and he has a low core temperature. Vital signs include a bicarb of 40, a pH of 7.45, and an ammonia of 800. So that is a very high ammonia level. I've seen some of the kids push 1,200, 1,500 ammonia. This is not a good thing. So this is classic for OTC deficiency or ornithine transcarbamylase deficiency. So again, sepsis is always more common than inborn errors of metabolism, but keep it in the back of your mind. This is a classic presentation for a urea cycle defect, normal at birth, male infant, raises the red flag for OTC because it's X-linked, and it's the most common out of all of the urea cycles defects, and it has a respiratory alkalosis and lethargy after 48 hours of protein intake. So it looked good, and now it's crashing. Rapid breathing can also be consistent with a ketoacidosis, and congenital diabetes is also a possibility. Any lethargy in a neonate, you have to consider hypoglycemia, so you're always pulling a blood sugar. All right, so now we're going to start at the very beginning. Carbamoyl phosphate synthetase, or CPS deficiency. Again, urea cycle defect, vomiting, lethargy, coma, high ammonia level. It's recessive, and you're having problems with breakdown of protein. You're going to have a low citrulline, a low arginine, a normal or low orotic acid, and a high ammonia. Okay, so back to our circle. CPS goes away. It makes your ammonia go up. Your orotic acid, it has decreased production. Your citrulline is decreased, and your arginine is decreased. And that's CPS 1. NAGS is going to look very similar. N-acetyl-glutamate synthetase. This is going to be very redundant for a little while. Urea cycle, vomiting, lethargy, coma, hyperammonemia. Autosomal recessive, and you can't start your urea cycle. Low citrulline, low arginine, normal to low orotic acid, and a high ammonia. So here's NAGS. It goes away. Your ammonia goes up. Your orotic acid goes down. Citrulline goes down. Arginine goes down. So CPS and NAGS are going to look similar on your laboratory studies. OTC deficiency, urea cycle defect, vomiting, lethargy, coma, high ammonia. Female carriers may be symptomatic with illnesses and protein load. So often we'll see women crash and burn after they've given birth. Never knew that they were a carrier before, but then they have a hyperammonemic crisis and go into a coma. Again, it's X-linked, problem with breakdown of protein. Now we're going to have low citrulline, low arginine, and now we're going to have an elevated orotic acid rather than low, normal to low. And we're going to have a high ammonia. All right, so here's OTC. You're going to back up the system with high ammonia and high orotic. Both of those are behind the block. Citrulline's on the other side, so it goes down, and arginine goes down. So that's OTC. Citrullinemia, arginosuccinic synthase, has a lovely abbreviation. No one proofed that before they decided that was going to be the abbreviation. Urea cycle defect, vomiting, lethargy, coma, high ammonia. If nothing else, that'll help you remember. It is autosomal recessive, problem with breakdown of protein, high citrulline, hence citrullinemia, low arginine, normal orotic acid because you're getting further away from that part of the cycle, and a high ammonia. Type 2 citrullinemia is a different enzyme and a different presentation. So this is type 1 citrullinemia. So again, here's the arginosuccinic synthase. So everything behind is going to back up. Citruline's going to go up. Ammonia's going to go up. Everything past that's going to go down. So arginine goes down. And that's citrullinemia. Arginosuccinic aciduria, or ASA, urea cycle defect, vomiting, lethargy, coma, high ammonia, and this one has a hair finding, Trichorhexis nodosa. So you get these little bulbs on the hair and this breaking. So you can pluck a hair, go look under the handy-dandy microscope, if anybody still has one of those in clinic, and be able to make your diagnosis without a fancy plasma amino test. It is recessive, problems with breakdown of protein. Now you're going to get high citrulline and high arginosuccinic acid, low arginine, and high ammonia. So we're now one more step down. So everything behind is going to go up. So arginosuccinate goes up, citrulline goes up, ammonia goes up. Arginine is still after the block, so it's still down. So this is arginosuccinic aciduria. Arginase deficiency is also known as argininemia. OTC is the unique one in being X-linked. Argininemia is the one that is unique in that its presentation is different. It presents as a progressive spastic di and or quadriplegia. It does not usually present with a hyperammonemic crisis. It's far enough away in the loop that they're able to manage their ammonia, but they'll present with a progressive cerebral palsy. So you should never have a progressive static problem. Tremors, ataxia, and chorioathetosis can also be seen. It's autosomal recessive, and you're getting a problem from the buildup of the arginine in the brain. So you're going to have high arginine and normal ammonia levels. So now we're all the way around the cycle. Arginine goes up, and this is argininemia. Because everything else now is so far behind, it's able to take care of and shuttle out into another area. So other things that are related to the urea cycle. Citrin deficiency is Citrullinemia Type 2. And it'll give you neonatal hepatitis, failure to thrive, and it can also give you adult onset liver failure. HHH syndrome gives you spastic di and quadriplegia, retinal depigmentation, and chorioretinal thinning. And LPI, which is lysine protein intolerance, can give you an interstitial pneumonia, glomerulonephritis, osteoporosis, and immune deficiency. So all of these may present with elevated ammonia levels, but it's something outside of the urea cycle itself. So we treat it by using alternative pathways to get rid of the ammonia. So we'll use phenylbutyrate because that acts as a nitrogen sink to take away the glutamine out of that system. And then we can also use arginine or citrulline as supplements to help drive the cycle around. Unless you've got argininemia, then you wouldn't be giving arginine. But everything else you can give arginine and citrulline. Increase your caloric intake. You want to protein restrict, but not too much, because if you don't have enough protein, you'll just break down your own. If your ammonias are so high, then you can do hemodialysis to pull off the ammonia. All right, so question number 1. A term newborn experiences tonic-clonic seizures and becomes apneic 12 hours after birth, requiring intubation. Prenatal history was unremarkable except for the baby having hiccups throughout the last trimester. Born vaginal delivery, APGARs 9 and 9. Family history is negative for seizure disorders. Physical exam is unremarkable apart from the seizures, and he is hypotonic. Trial of phenobarbital and phosphonitoin, and the seizures stop. However, he's not having any respiratory effort and remains intubated. Most likely cause for the seizures is Acardie syndrome, benign familial neonatal seizures, hypoxic ischemic encephalopathy, nonketotic hyperglycinemia, or pyridoxine dependency. All right, so the most likely cause is nonketotic hyperglycinemia. The in utero hiccuping and presenting at 12 hours. Usually 12 hours is pretty early for something like a urea cycle defect, PKU, MSUD. You need something to come into the system for 24 to 48 hours. So 12 hours is a really early presentation. So knowing that NKH can actually start in utero with those in utero hiccups, which are seizures, that 12 hours is a pretty classic presentation for that. Familial seizures are dominant and characterized by 10 to 20 seizures a day, starting at about 3 days of age. HIE is unlikely. The kid's been vigorous and doing well, APGARs of 9 and 9. He's non-dysmorphic, making Acardie unlikely. And pyridoxine dependency would be refractory to the phenobarb and the phosphonitoin. All right, organic acidemias and acidurias. And so the disorders are due to buildup of keto acids and defects in amino acid metabolism. So we see a 16-month-old male who woke up this morning with an acute onset of weakness and lethargy. He woke up at 5:30 and took a sippy cup, then went back to sleep. Woke up at 7:30 with decreased responsiveness and dilated pupils. They called the ambulance. He was taken to the ER. And upon arrival, he was gasping with decreased level of consciousness, and he was intubated for airway management. It was a normal delivery at 37 weeks, no problems, no hospitalizations, no surgeries. Developmentally on time prior to this event, walking, talking, and normal for age. Respiratory rate, pulse, blood pressure. Exam, he's responsive only to pain, limp with minimal movement of extremities. His admit labs shows a low bicarb 5.7, ammonia is 57, his pH is 7.03, and a base excess of 24.3. He initially did well with IV hydration and glucose, became hyperglycemic, so they decreased the glucose, and then became acidotic again. Restarted the glucose with good resolution of the acidosis. And the diagnosis here is Methylmalonic Aciduria. When you look at the urine organic acids, you'll see massive elevations of lactic acid and methylmalonic acid. And that's where your base excess is coming from. You're making a bunch of extraneous acids that didn't need to be there. The plasma amino acids have elevations of glycine. The Acylcarnitine profile will show elevated excretion of Propionic and Methylmalonic Aciduria. Common to all of the organic acidurias is a high anion gap and a metabolic acidosis. So organic acidemias are a group of disorders that are due to problems with breaking down selected amino acids, fatty acids, and carbohydrates. And the symptoms result from a buildup of keto acids. They usually present in the neonatal period or with intermittent illness. So if it's really bad, you'll start off bad in the nursery. The more mild forms, you're going to wait until you get sick as a toddler and then go into a crisis. So you'll see ketoacidosis, hypoglycemia. Some will have bone marrow suppression. And those abnormal acids, the more acidotic you get, it impairs your urea cycle. So you get a secondary impairment and an elevation of your ammonia. But the ammonia should not be as high as the people who have a true inborn error of their urea cycle. So you want to get plasma aminos in urine organics. That's going to take about 1 to 2 weeks to come back. That's not very helpful in the ER. But once you get the test results back, you can make a very good diagnosis because you'll know, again, A, B, and C, what's up, what's down. Once you know what you're sort of looking for, you can do enzyme diagnosis on white blood cells or fibroblasts. Again, low protein diet, restrict what is the offending agent, special formula that doesn't have the offending agents, and supplement with biotin and carnitine. So talk about maple syrup urine disease, or MSUD. The incidence is about 1 in 150,000, except if you're old order Mennonite. It's about 1 in 176 births. So if you live in Pennsylvania, Ohio, Indiana, we've tested for MSUD on newborn screening for a very long time. Other states did not. But you now can pick that up as part of the expanded newborn screen. It's a defect in breakdown of branched chain amino acids, which are valine, isoleucine, and leucine. So all three of those will be up. The pathognomonic compound here is allo-isoleucine. And you'll see that in the plasma and in the urine. Generally presents with CNS symptoms. They have an unusual odor from which it gets its name, maple syrup. The onset is about 3 to 5 days of life with feeding problems, low glucose, seizures, lethargy, coma, and finally death without treatment. Okay, so isovaleric acidemia is the odor of sweaty feet. It gives you an encephalopathy. Chronic form can have pancytopenia and chronic acidosis. Propionic and methylmalonic present with ketoacidosis, can also have osteoporosis, and a event can be triggered by infection, and may initially be misdiagnosed as a pyloric stenosis with the amount of vomiting that's going on. Glutaric acidemia type 1. Infants are macrocephalic at birth. They can have cortical atrophy. They rarely ever have frank metabolic acidosis. It's common in the Amish population and is one of the few causes of retinal hemorrhages and subdural hematomas that are not from shaken baby. So always keep that in the back of your mind. If you're doing an NAT eval, thinking about getting plasma aminos and urine organic acids to make sure it's not a rare cause of retinal hemorrhages or subdurals. Propionic acidemia is autosomal recessive. It's a Propionic-CoA carboxylase deficiency. You get a ketotic hyperglycinemia as opposed to a non-ketotic hyperglycinemia. Again, we'll give you mild to moderate hyperammonemia because of the amount of acidosis that's going on. It's impairing the urea cycle. High anion gap metabolic acidosis. Clinical complications include cardiomyopathy, dermatitis, pancytopenia, and pancreatitis. Diagnostic tests include urine organic acids for the specific metabolites, looking for propionylcarnitine, 3-hydroxypropionic acid, and 3-methylcitric acid. On the plasma amino acid, you'll see elevated glycine, and your glutamine may also be elevated. So you want to restrict your branched-chain amino acids and your overall protein intake, correct your metabolic acidosis, and during crisis, make sure you're getting lots of glucose. What you're trying to do with all of these is shut down catabolism. Okay? Sugar never hurt anybody. You can always push more sugar while you're waiting to try to figure out what's going on. All right, you are urgently called to the newborn nursery to evaluate a 3-day-old term male infant who is lethargic. Baby was taking formula well for the first 2 days, but vomited after his last 2 feedings and has become increasingly difficult to arouse. Pregnancy, labor, delivery were uneventful. APGARs were 8 and 9, and family history is non-contributory. Physical exam, the baby is limp, lethargic, and unresponsive with tachypnea. You order a series of lab tests, start IV fluids, and arrange for transfer to the neonatal intensive care unit. Your lab values include platelets of 35, carbon dioxide of 45, ammonia of 600, total bili at 20, and no ketones in the urine. The most likely diagnosis is bilirubin encephalopathy, citrullinemia, hypoxic ischemic encephalopathy, propionic acidemia, or transient hyperammonemia of the newborn. Oh, we almost got a perfect split. Good job. This is citrullinemia. This is a classic presentation with a high ammonia after several protein feeds. The ammonia is not going to be as high as it is with OTC. OTC, you're going to get 800, 900, 1200, 1500, obnoxiously high ammonias. Citrulline is going to have more like in the 600 to 400, which is also going to be where your acidemias are going to hang out as well, sort of in that 400 mild elevations. Propionic acidemia could be possible, but you would expect a high anion gap metabolic acidosis because you're making an abnormal metabolite. So that base excess is going to go up and you're going to have abnormal keto acids. Transient hyperammonemia is almost exclusively seen in preterm infants who have symptomatic pulmonary disease, and they become comatose and develop seizures in the first 24 hours and even before introduction of dietary protein. Bilirubin is unlikely to be a cause of high ammonia, and the normal delivery and initial time frame make HIE unlikely. All right, back to sugars. Everybody loves sugars. So this is, again, buildup of products that poison cells and intoxications, but from the sugar products. Here's a case, 5-day-old male that's admitted to the NICU from May 11th to May 15th for management of his hyperbiliry. He was discharged from the nursery on 5/8 initially, so 3 days prior. Then followed up in the pediatric clinic on May 11th for his 1-week checkup and was observed to be jaundice with a total bili at 32, and that's what got him admitted. So went to the NICU for a possible exchange transfusion, and his underlying diagnosis is galactosemia. His total bilirubin on admission was 32.2 with a direct of 0.9. The bili came down with phototherapy. Initial coags, PTT, was elevated at 62. He was given FFP, repeated the PTT, it went down to 45. The newborn screen came back, positive for galactosemia. We switched to a soy formula and has done well since then. So for a while they were making lactose-free formulas. There's always a lactose-free formula. It's called soy. So it's a marketing ploy. If you want a lactose-free formula, use soy. Something that's labeled as lactose-free is things that are like fat-free. There's still fat in it. There's still lactose and lacto-free. If you're having a problem with lactose, just give them soy. All right, classic galactosemia is due to a problem in the breakdown of galactose. And the reason why lactose is a problem is because lactose is a compound of glucose and galactose. Classic galactosemia occurs at about 1 in 50 to 1 in 100,000 people, primarily due to a deficiency in galactose-1 phosphate uridyl transferase, otherwise known as GALT. Clinical features include vomiting and diarrhea in the first weeks of life, liver disease with jaundice, cataracts, and the ever infamous E. coli sepsis. So when you see E. coli sepsis, you should think about galactosemia. You diagnose it on newborn screening with a low GALT level, enzyme level, and a high galactose-1 phosphate, or Gal-1P. You can also have positive urine-reducing substances, which is the galactose being spilled out in the urine. And the treatment is a lactose-free diet, which is your soy formula. There are less common forms of galactosemia, like galactokinase deficiency and epimerase deficiency. They generally do not present as neonates. All the galactose metabolism, though, can cause cataracts. And these two are not detected on newborn screening because what we're actually testing for is the specific GALT enzyme. Hereditary fructose intolerance occurs in about 1 in 20,000 people of European extraction. It's less common in other populations. It's a deficiency of fructose 1,6-bisphosphonate, bisphosphate aldolase. The accumulation of the fructose 1-phosphate, it gives you your toxic symptoms. And you're healthy until you ingest fructose or sucrose. And sucrose is a disaccharide of glucose and fructose. So what do we put in everything now? High fructose corn syrup. Remember, I'm from Iowa. We put corn in everything. So it's really easy for, once you get to about 6 months of age, you give your kid something that you don't think has any fructose in it, but it's been sweetened, artificially sweetened with the high fructose corn syrup. So you typically present at about 6 months of age when you introduce fruit and fruit juices. You get jaundice, hepatomegaly, vomiting, lethargy, and seizures. Because you're having liver damage, you're going to get prolonged clotting times, low albumin, hyperbiliary, abnormal LFTs. You're going to get a proximal renal tubular dysfunction, severe episodes of hypoglycemia, and you're also going to have positive urine-reducing substances. We treat it with a diet that goes without sucrose, fructose, or sorbitol. And then you can watch the liver and kidney damage resolve. Mental retardation is uncommon. It's really just a liver injury problem from the breakdown products of the fructose. All right, you're reviewing the formulas your hospital keeps in stock in case you get a sick infant on the weekend, because we all know that's what you like to do on a Friday. Okay? Which disorder is best treated with a commercial soy formula? Citrullinemia, hereditary fructose intolerance, Tyrosinemia Type 1, PKU, or galactosemia? Correct answer is galactosemia. Soy formula is the first-line treatment when you diagnose somebody, or if you've just admitted them and you are suspecting that diagnosis. Nobody was ever hurt by putting a baby on soy while you waited for lab tests to come back. The mom might be mad at you when she's breastfeeding, but it's okay. You can do 3 or 4 days of soy formula and get back to breastfeeding. Urea cycle defects require low protein supplementation, but not soy. PKU and tyrosinemia have special formulas that are low in Phe and tyrosine. And HFI, or hereditary fructose intolerance, requires restriction of sucrose, not galactose. Sucrose and fructose and not galactose. All right, so those are your intoxications. Now we're going to go to energy metabolism defects. So now we're back to A to B to C, and when A cannot go to B, C goes down. When C goes down, then you're not going to have enough energy to keep going. So now it's no longer a problem of A backing up, but not enough getting through. So you can have problems of free glucose, you can have problems of your glycogen stores, you can have problems of proteins and fats, and you can have problems of your mitochondria that will give you problems with energy production. So defects in making or breaking down glycogen, GSD or glycogen storage disease type 0, 1A and 1B, GSD type 3, and McArdle's disease we'll talk about. Fatty acid oxidation defects like MCAD, VLCAD, and LCHAD, and these are all screened for on expanded newborn screening with tandem mass spec. The Krebs cycle problems are in mitochondrial respiratory chain problems, so congenital lactic acidosis, your respiratory chain complexes 1, 2, 3, or 4 defects, a COX deficiency, or pyruvate dehydrogenase deficiency. So you're unable to use your normal resources of stored energy. And the problem can be anywhere in your ATP cycle, fatty acids, glucose, or protein. Fasting or illness with increased energy needs can exacerbate the disorder and bring on a decompensation. Hypoglycemia is usually your last sign. You know, babies always lie. Never trust a baby. They will often be lethargic prior to a complete collapse. So even if you're getting a normal glucose, but you have this lethargic baby, you need to be very vigilant. So they can present with failure to thrive, low glucose, a lactic acidosis, low tone, a myopathy, cardiomyopathy, and about 3 to 6% of SIDS case are result from a fatty acid oxidation defect. Look at the mom's pregnancy history. Often you'll find HELP syndrome or an acute fatty liver disease. The diagnosis can be difficult, and the findings on screening tests are usually nonspecific. The exception is the fatty acid oxidation disorders that can be detected on newborn screening. Likely we'll end up doing a skin, muscle, or liver biopsy to confirm the diagnosis. Mitochondrial disorders can be problematic because the mitochondria mutations have different populations in different tissues, so you might need to test multiple places to make that diagnosis. All right, so we're going to do fats first, fatty acid oxidation. So beta oxidation of fatty acids occur in the mitochondria, and this provides energy for skeletal and heart muscle during fasting from fat breakdown. That's why we all put on our extra layers of fat. You generate Acetyl-CoA, and this is used for ketone body production rather than glucose. And you get progressive fatty acid chain shortening and carnitine transport are both important in these disorders. So the way this goes is you have carnitines that are long in length, and they get taken off 2 carbons at a time. So you go from a C14 to a C12 and pop off an acetyl-CoA. Pop off another 2, and now you're down to a C10, and you've generated another acetyl-CoA. So depending on where your defect is whether or not you're a very long chain, a medium chain, or a short chain. So whenever you look at your acylcarnitine profile, knowing are you elevated in your C6s, your C10s, your C14s, your C18s, tells you are you short, medium, long, very long. So clinical lab abnormalities is a hypoketotic hypoglycemia. So you've got a low sugar, you're not being able to support it with the breakdown of fats, and you're not making enough acetyl-CoA to make ketone bodies. Your uric acid can go up. You can also have a mild elevation in your ammonia. You can get a dicarboxylic aciduria and acidosis. MCAD is the most common disorder of fatty acid oxidation. and it usually presents in the first 2 years of life. It gives you fasting-induced vomiting, lethargy, seizures, and coma. It is a rare cause of SIDS, although once we found this, we knew that our SIDS cases went down. Prior to newborn screening, about 25% of people with MCAD died with their first illness. So now we can test for it on newborn screening. We have an elevated C8 and then the C8-1 and C10-1 esters. You want to make sure you're having frequent feedings with carbohydrates, and you're going to supplement with carnitine. So these are not the kids you want fasting overnight. So there's a breakdown. You can't go from C8 to C6, and the C8s go up. And you also get sort of a backflow to the C10s. So typical case presentation, 18-month-old boy has not been eating well for the past 2 days. He's had a fever since this morning. His mother is worried because he just isn't acting like himself. He's not playing. He's sleeping all the time. And he had an older sister who was found dead in her crib after a similar episode at 12 months of age. So has a white cell count of 4.2 with lots of lymphocytes. Has a glucose of 40. Ammonia mildly elevated at 180. He has hepatomegaly, or a big liver. He was born out of state and did not have expanded newborn screening. This is becoming less and less problematic as more states go to expanded newborn screening. But again, know what your state does and find out where people were born and what that state does. You cannot make the assumption that just because your state does it, some other state does exactly the same thing. You get the following test while you're starting an IV, a free and total carnitine level and an acylcarnitine profile, which will come back 2 weeks from now, which won't help you right now with your initial management. The final diagnosis is MCAD, or medium-chain acyl-CoA dehydrogenase deficiency. Acylcarnitine profile showed elevated C8 and the C8-1 and C10-1 esters. They develop hypoglycemia when forced to rely on fat for their energy. So this baby was fasting overnight like he usually did. However, now he's sick. He has a fever. He's catabolic. He needs more energy stores. And now he wants to use his long-term energy and his fats, and he can't get all the energy out of the fat that he needs. And the big tip-off, we've got a dead sister at about 12 months of age from SIDS. So because this is a recessive condition, you're going to presume that that little one also had an identified MCAD and died from a hypoglycemic episode. About 3% of SIDS deaths are fatty acid oxidation defects, and MCAD is the most common fatty acid oxidation defect. Check a glucose, but if it's normal, don't assume that you're out of trouble. Because if you're in a chronic catabolic state, you don't know where that final tip-off point is going to be, and you're going to crash and burn. Very long chain, VLCAD, heart and skeletal muscle are most affected. Because it's very long chain, you're going to see earlier onset of symptoms. Long chain, or LCHAD, liver and heart, again, most affected because it's long chain, earlier onset symptoms, and you can also have retinal changes. SCAD, short chain, may or may not get hypoglycemic. When geneticists all sit in a room like this, we argue about whether or not this is a disease or not. It is a biochemical abnormality that we can pick up on a screening test, but by and large, these people don't get hypoglycemic. And because it's a short chain, you really are getting the most out of all your fats. So you're still able to compensate for a very long time. You can also have problems with pulling your acylcarnitines into the mitochondria so they can actually go through fatty acid oxidation. So enzymes and diseases that are transporters are carnitine palmitoyl translocase, acylcarnitine translocase, palmitoyl translocase 2, and a carnitine uptake deficiency. So anything that impairs the ability for the fats to get into the mitochondria so they can be burned for energy will look just like a fatty acid oxidation disorder. And they'll look like the long chain disorders. Have effect sooner, and liver and heart will also be affected. All right, moving back to glycogen. So we have to take our sugar and we have to put it away in the bank for later use. And when we do that, we make glycogen. When you have GSD type 0, you can't even get it in and get it stored into the chains. GSD 1A and 1B, you have a problem in breaking down your glycogen due to glucose 6-phosphatase deficiency. GSD type 3 is a debrancher, because remember, you make a tree out of all of your glycogen, you have to keep branching. So to get it back out, you have to debranch and keep rearranging things. So with GSD type 3, it's a debranching problem. Problem here is then you can't retrieve your glucose from your stored glycogen. And so this is a short, fast hypoglycemia, because this is your first reserve, is your glycogen. Your fats are your long-term. Then you also have problems with the cells that are trying to store all this excess glycogen that they can't get back out. So then you also have local effects from the stored glycogen. So you see a 19-month-old female that has hepatomegaly, increased transaminases, as well as an episode of hypoglycemia. Although she's doing generally well, she's small. She had some developmental delay and was noted recently on a hospitalization to have hepatomegaly with feeding intolerance and vomiting. During her hospitalization, she had a blood glucose of 44, increased transaminases, and a bilirubin of 0.8. She was referred to pediatric GI. Repeat labs 3 days later have increasing transaminases than ALT and AST that have now doubled. And this is classic for GSD type 1A. Total protein was on the lower end, albumin, mid, and uric acid, although in this case was normal, can be severely elevated. Her cholesterol is elevated and her triglycerides are elevated, which is classic for GSD type 1A. And she had a mutation analysis consistent with a GSD type 1A. So again, this is a defect in glucose 6-phosphatase in liver, kidney, and the intestinal mucosa. So you store your glycogen, but you can't get it back out for glucose. 1A is glucose 6-phosphatase. 1B is a translocase defect. So you have fasting hypoglycemia presenting at 3 to 4 months of age when you're starting to try to wean off and trying to get some sleep as a parent. They're getting a bigger and bigger liver because they can't get their glycogen back out of the liver. They're starting to have seizures from the hypoglycemia, doll-like facial features, and a protuberant abdomen. Long-term, they have liver disease, gout from the elevated uric acid, can have delayed puberty, pancreatitis, hepatic adenomas, kidney stones, and high blood pressure. So the key lab findings: hypoglycemia, lactic acidosis, because you're going to have to start making your energy some way, so you're going to start generating lactate. High uric acid from the breakdown of protein. High lipids from the breakdown of fat for your energy. Elevated liver enzymes because you're storing too much glycogen. Type 1B actually is associated with neutropenia. And you're going to make lots of ketones because you're using fat and protein for your energy. So if you have a fatty acid oxidation defect, you can't make your ketones, but if you're having a glycogen problem, that's what you're really going to start to rely on to make your energy. So now we can do gene-based mutational analysis that's definitive, and a liver biopsy is no longer required to diagnose GSD. You want to keep these people going with as much slow infusion of a carbohydrate as you can. And so you can either do continuous NG feeds. When the kids get a little bit older, then you can do uncooked cornstarch, and your gut mucosa will begin to break down the starch and have a slow release of glucose over time. Eliminate your fructose and galactose from your diet, and then you can also give allopurinol for the elevated uric acid. So other types of GSD, if you can't make glycogen in GSD type 0, your liver isn't going to be big. GSD type 3 with debrancher, you're going to have an accumulation of abnormally structured glycogen in the liver and heart, and these kids will also present with hypoglycemia in infancy. McArdle's is also a glycogen storage disease, but it affects primarily the muscle. This is GSD type 5. It's an autosomal recessive condition. Usually presents in young adults or teens, and these are the non-athletic people that get frequent muscle cramps with rapid exercise. If you have them exercise and they get the muscle cramps and then check their CPK, the CPK starts to go way up, and you can actually drive them into rhabdomyolysis and myoglobinuria. So you can see the differences here in the urine. And that can lead to acute renal failure, and so we need to bring those people in, alkalinize their urine, and get them through that event. They can have progressive muscle weakness and atrophy with with fat replacement. All right. Another question. 6-month-old child is admitted to the hospital for evaluation of failure to thrive after waking up this morning with a seizure. Upon arrival to the emergency department, she was still seizing and her glucose was 10 on a finger stick. Physical exam, she appears wasted and has a protuberant abdomen and marked hepatomegaly. She has fasting hypoglycemia, lactic acidosis, high uric acid, and high lipids. The best long-term management of this disorder is oral dietary supplementation with long-chain fatty acids, dietary supplementation with protein, IV administration of 10% dextrose, IV administration of glucagon, or oral administration of cornstarch. So for the few people that pick 10% dextrose, that's good for your immediate resolution of the problem, but not good for the long term. So there's a difference between when they ask you about immediate things to do. Giving sugar never hurt anybody. That's always a good response. But over the long term, you're not going to keep an IV in. And this is a classic presentation for a GSD, especially with the elevated lipids and the elevated uric acid. And so again, you use the cornstarch to give you a slow release of glycogen. Fatty acid and protein supplementation won't address the original problem. Glucagon will force the body to release whatever glycogen it can, but if you're having a problem getting it out, glucagon really isn't going to be of any help. And again, the IV dextrose, you can't keep going with that, and it doesn't address your long-term problems. Okay, mitochondrial. So there are defects in the respiratory chain pathway, and you're unable to convert any of the byproducts from glucose, fat, or protein into ATP. So it's sort of your end of the pathway. All of this stuff is being given to you, and now you have to churn it out into real energy. Variable presentation and variable age of onset. The mitochondria, remember, are the power plants for all of our cells in the body. It's where all of the compounds come to so we can burn it and create energy. When your cell needs more energy, the cells make more mitochondria. Remember that the mitochondria have their own DNA. It's a little piece of circular DNA which is autonomous from ours. There are multiple mitochondria in every cell, and they're necessary for aerobic ATP production, and they divide independently of our own cell cycle. So disorders of the mitochondria metabolism can evolve in 5 different ways. You can have a true mitochondrial disorder where you have a mutation in that little circular mitochondrial DNA. And that's our true maternally inherited mitochondrial disorder. Probably 95%, however, of what works in that power plant is encoded by us and shipped in. So you can also have dominant, recessive, and X-linked conditions that give you mitochondrial problems and the mitochondria don't work. You can also damage your mitochondria, so from medicines that you take or from radiation. So you can have environmental concerns that give you mutations and decrease your mitochondrial efficiency. There are more than 40 different mitochondrial diseases that have been identified. There's a concept of heteroplasmy. Within each cell, you have multiple mitochondria. So that population of mitochondria is not homogeneous. One might collect a mutation and then give rise to a whole subpopulation of a mutated mitochondria. Different cells in different places in your body may have different composites of mutated mitochondria and not. So whenever you take a blood sample looking for mitochondrial mutations in that little circular DNA, it may or may not be representative of what's going on in the whole body. And so this is the issue of heteroplasmy, that there's this whole other population of mitochondria in our body that may not be homogeneous. Reasons why I dislike mitochondrial defects. They can give rise to any symptom in any organ or any tissue at any age. Mitochondrial disease is on any list of anything you will ever see. Okay? So just keep it on your list, work your way towards it. But there are some defining characteristics. Your main phenotype is going to be driven by energy deficiency. So things that have a high energy demand, you're going to see problems in first. Your heart needs a lot of energy. So if you're having a cardiomyopathy, you might want to consider a mitochondrial disorder. Neuromuscular disorders, seizures, overall poor growth and failure to thrive. Problems with your CNS, the way that you see and you hear, those all are high energy systems. Those are going to be affected first. So the classic mitochondrial disorders include Elhan or Leber's hereditary optic neuropathy, MELAS, mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes, Kern-Sayre syndrome, Lee syndrome, and MRF, myoclonic epilepsy and ragged red fibers. So again, here's a sperm going and fertilizing an egg, and you can see here this happy ovum has a wondrous representative 3 mitochondria that are now over here and dividing. This one has another one that has a mutation. So everything here then is going to give rise, and those cells will have a mutated mitochondria. So if it is a mutation in the mitochondrial DNA, it is maternally inherited. The sperm use all of their mitochondria to swim. All of your mitochondria came from your mom. Okay, so here's the same thing. You have one that has the mutation. It's going to divide. It's going to keep dividing and keep dividing. So you're going to end up with a subset of cells that have defective mitochondria. So that was an inherited. This one's doing fine. This group's doing fine. Now you've taken a hit with some radiation or some environmental exposure, and then after that you're going to get a collection of mitochondria that have a mutation in it. So again, that idea of heteroplasmy and mosaicism. So first thing, look at your blood when you want to try to make the diagnosis. Look at your lactate and your pyruvate, because that's going to tell you your oxidation or your redox status. What are you doing? Are you aerobic or anaerobic? What are you doing with your electrons? This may be elevated, and it depends on the impact on your aerobic metabolism. However, lactic acid can go up if you're struggling with your blood draw, okay, because you're depriving that area of oxygen. And you know kids are always easy to draw blood on. Plasma amino acids, proline and alanine elevations may indicate a mitochondrial dysfunction. And then mutation analysis can be tricky due to that heteroplasmy. And then whether or not this is a true mitochondrially inherited disorder versus something that is inherited from our own genome, whether or not it's a nuclear DNA mutation. So it's better to have an idea of where your defect is occurring in the functioning before you go on a wild goose chase. There's no good evidence for treatment. There are no case-controlled studies or controlled trials, and outcomes are subjective. But we do like to give people things because it makes us feel better, even if it doesn't make our patients feel better. So give them antioxidants to help with their free radicals and reducing damage, coenzyme Q, lipoic acid, vitamin C, vitamin E, and then trying to stabilize your complex 1 with carnitine, thiamine, pantothenic acid, and riboflavin, so a mitochondrial cocktail. All right, question number 5. 4-month-old is brought to the emergency department, found limp and apneic in his bed this morning, unable to be aroused. Mother reports he had been healthy and developing normally. Yesterday he developed a little bit of diarrhea and vomited once. Reports that he fed normally at 8 p.m. and went to bed. He's been sleeping through the night for the past 2 weeks. Physical exam, his growth is normal. It's pink and stable on his D10 at maintenance after initial resuscitation in the ambulance. His initial labs included a serum glucose of 15, blood pH of 7.2, carbon dioxide of 50, no ketones, and otherwise normal. Most likely disorder in this child is fatty acid oxidation, gluconeogenesis, glycogen degradation, lysosomal storage, or protein catabolism. So this one is the fatty acid oxidation. They're not making any ketones. If it was a glycogen problem, you would rely on your fatty acids and start generating ketone bodies. And then protein metabolism tends to present with ketotic metabolic acidosis, not typically with a hypoglycemia, although it can be present. And then we're going to get to lysosomal storage diseases. They usually are a long-term problem and not an acute issue. All right. Out of all my time of teaching metabolic stuff and then taking PEDS tests, this is what I think they really want you to know. Is what do you do with the child who has hypoglycemia? Because none of these kids come in and go, hi, I have methylmalonic acidemia. Will you help me? You're just sitting there at 2 o'clock in the morning going, start an IV. And freaked out. Okay. Big liver, GSD, galactosemia, hereditary fructose intolerance, anything that injures your liver. Too much insulin, pituitary problems, organic acidemias, not a big liver. If you got reducing substances, you've got galactosemia or HFI. If you don't, you have a glycogen storage problem. You can't even get your sugar back out to spill into your urine, and fatty acid oxidation defects. Do you make ketones or don't you make ketones? And what happens if you give the patient glucagon? Those are always the key things that they look for in those vignettes. They're going to give you some combination of hepatomegaly, reducing substances, ketones, and glucagon. Now we're to complex molecules. It's really about 2/3 of the way through. Okay, so the first two groups I lovingly call the death and dying acutely kinds of diseases. These are the kill you slowly diseases. So things that are complex molecule defects include our lysosomal storage disorder, peroxisomal storage disorders, problems of intracellular trafficking and processing defects such as metal metabolism, alpha-1 antitrypsin deficiency and Wilson's disease, and congenital disorders of glycosylation. There's also inborn errors of cholesterol synthesis. These symptoms are permanent. Once they're there, they're there. They are progressive over time. They are independent of other events. So it doesn't matter if you have a fever or not. It doesn't matter if you're catabolic or not. These are slowly progressive. They do not wax and wane. They often have multi-organ involvement, and any type of storage will go to the soft tissues first. So liver, spleen, heart, joints, and airway. Some general screening tests that can be helpful: urine oligosaccharides, urine mucopolysaccharides, lysosomal enzyme studies, very long-chain fatty acids, which are different than an acylcarnitine profile. You're looking at fatty acids that are even longer than what you get on an acylcarnitine profile. And serum sialotransferins. Results are dependent on the lab that runs them. Do you want to have your heart bypass done by the guy who always does appies? No. You want it done by the guy who's done 300 bypasses in the last 2 weeks. Okay? You want your labs done by the people who always do those labs. You don't want it done by the guy who only does it once a year. For definitive diagnosis, you'll likely need enzyme studies or mutational studies. Until about 10, now going on 15 years ago, the answer was just symptomatic management for treatment. But we've now developed enzyme replacement therapies for several of the lysosomal storage defects. But you still have to manage the symptoms and be aware of the common complications that occur. And remember, these diseases are progressive disorders. They are not static. What is happening now at the age of 5 is not what they're going to look like at the age of 15, 35, and so on. So lysosomes are where we store things to be broken down. It's sort of like the trash dump. And we want it to be broken down and reutilized. And so these are the sites of degradation in target organs for macromolecules. And these problems in these lysosomes and breaking things down give you mucopolysaccharide cytoses, oligosaccharidoses, gangliosidoses, which are also known as sphingolipidoses, and then related lipid storage diseases. Most are autosomal recessive with the exception of Hunter, which is a mucopolysaccharidosis, and Fabry's disease. Both are X-linked. So these kids all look normal at birth. If you ever see a child with developmental regression, that is bad. It is not normal. Again, all disorders are progressive and most are fatal. Glycogen storage disease type 2 is actually a lysosomal storage disease. So you'll see it under GSD, and you'll also see it under lysosomal storage. It's much better categorized as an LSD as opposed to a GSD. It's also known as Pompeii's disease. If anybody's ever seen Extraordinary Measures, that's what the kids have in that movie. Instead of a mucopolysaccharide, this is a glycogen that accumulates in the lysosome. So rather than the glycogen not being able to get out of the liver, the glycogen gets stored in lysosomes. The infantile form gives you cardiomegaly, hypotonia, and death usually less than a year of age. You can have a high voltage QRS and a shortened PR interval on your EKG. Juvenile form, slowly progressive skeletal muscle involvement without the cardiac involvement. And then adult can onset anywhere from 20 to 70 years of age, and it's a slowly progressive myopathy with the lower extremities more affected than the upper extremities and no cardiac involvement. The MPSs, or mucopolysaccharidosis, are defects in catabolism of glycosaminoglycans, and they have accumulation of dermatan, heparin, and keratin sulfates. Have three different forms that can be seen: a dysmorphic syndrome, learning difficulties, behavior problems, and dementia, and then a severe bone dysplasia. So the most common phenotype that you see is a coarse facial feature, distinctive bone changes known as dysostosis multiplex, joint stiffness, a big head, hernias, thickened mucosa, so these kids always come in with a snotty nose, recurrent ear infections, corneal clouding, deafness, and mental retardation. The classic for this is MPS type 1, which is Hurler syndrome. It's autosomal recessive. Typical features: severe, diagnosed in the first 2 years of life. Milder forms can be diagnosed later. Coarse, large tongue, frequent URIs, hernias, inguinal and umbilical, big head, obstructive sleep apnea, poor growth, corneal clouding, deafness, and mitral valve disease, because that's also getting stored on your mitral valve. This has an enzyme replacement therapy. It will not affect, however, your brain development because it won't cross the blood-brain barrier. If you can catch them before 18 months of age, you can do a bone marrow transplant before the intellectual deterioration, but the bone marrow transplant will not stop the skeletal abnormalities that are already there. MPS 2 is Hunter syndrome, which looks very much like Hurler syndrome, except this one is X-linked. Severe looks similar to MPS type 1. A more mild version is out there that has a normal lifespan. And the other difference between MPS 1 and MPS 2 is not only mode of inheritance, but MPS 2 does not have the corneal clouding. And this one also has enzyme replacement. The other two that can come up on tests are Sanfilippo's and Morquio's, so type 3 and type 4. Sanfilippo is recessive, usually diagnosed by about 4 to 5 years of age. They have severe CNS problems and actually can have developmental regression. They have very mild physical symptoms. They may not have hepatomegaly like the other MPSs. And there's a classic triphasic pattern with severe behavior problems. So they look like they're chugging along just fine, and they sort of slow down, lose skills, and become very aggressive. Morquio's is also autosomal recessive, but this is characterized by a short trunk dwarfism. So remember, achondroplasia is the most common dwarfing condition and is a short limb dwarfing condition. Morquio's is a short trunk, so the arms and legs are the right length, but the spine didn't grow as much as it should. They can also have fine corneal deposits and spondyloepiphyseal dysplasia, which is unique to Morquio's. And they can also have odontoid dysplasia. They have normal intelligence, so different than Sanfilippo's, Hunter's, Hurler's. All right, moving on to the sphingolipidoses. This is the classic example is Tay-Sachs. Primarily affects the CNS, caused by deficiency of the alpha subunit of hexoaminidase A. It causes accumulation of GM2 gangliosides in the neurons. The incidence is about 1 in 100,000, with 0.3% of people being carriers. If you're Ashkenazi Jewish background, you have about a 1 in 4,000 incidence with 3% carrier rate. This is the classic cherry red spot that you can see on a retinal exam. Has a very characteristic clinical course. Usually looks normal at birth. By about 6 months, becomes hypotonic with an exaggerated startle. Between 6 and 12 months, that you can start to see the cherry red spot becomes spastic and rigid. You're beginning to notice the delays. 12 to 18 months, excessive drooling, bouts of unmotivated laughter, and seizures. 18 to 24 months, you're getting a bigger head, megalencephaly, cortical blindness, quadriplegia. And then between 2 and 4, you're starting to get the contractures, autonomic dysfunction, and finally death. It's autosomal recessive. You can diagnose it with an enzyme assay. You can do DNA diagnostics in high-risk populations. So there are 3 mutations that are responsible for 98% of all cases of Tay-Sachs in the Ashkenazi population. Based on that, they've undertaken heterozygote screening in different populations. Different populations will handle it differently. Some will do it in childhood, so that way the matchmaker will match you with somebody that is not a carrier. In others, they just offer it as a pre-marriage or pre-pregnancy screening and counseling. So it really depends on which community you live in. But we've decreased the rate of frequency of Tay-Sachs in the Ashkenazi population by that technique. Gaucher's disease is glucocerebrosidase deficiency, types 1, 2, and 3. Type 1 is the non-neuronopathic form. Type 2 is the acute neuronopathic form. And type 3 is a chronic neuronopathic form. Big liver, big spleen, low platelets, anemia, leukopenia. You can get an osteonecrosis and avascular necrosis, osteopenia, and their pathologic fracture is an Erlenmeyer flask deformation. Types 2 and 3 now have CNS impairment, and they're just differentiated by the age of onset, early versus late, and they may also have eye problems, apraxia, and nystagmus. So you need to monitor for known complications, liver and spleen. Don't take out the spleen. There is an enzyme replacement, so you can get the spleen to come down in size. Treat their bone involvement and pulmonary complications. Treatment of current problems includes their liver dysfunction and thrombocytopenia, and there's an element of pain that's involved with this condition as well, so making sure they have good pain management. And there's enzyme replacement for type 1, but again, type 2 and type 3, because it has to pass through the blood-brain barrier, is not going to be effective. And so for that, you want to do stem cell transplants for type 2 and 3. Niemann-Pick, A, B, and C, is autosomal recessive sphingomyelinase deficiency. A and B is the same gene, but differing amounts of enzyme. Type A is an infantile onset and early fatal, enlarged liver and spleen, failure to thrive, progressive deterioration of the nervous system. Type B is an adult, non-neuronopathic form with growth retardation and recurrent lung infections. Type C is a different gene, but gives you severe liver disease, breathing difficulties, developmental delays, seizures, dystonia, poor coordination, and inability to move the eyes vertically. And this can onset any time from infant to adulthood. And for this one, you also want to look for loss of skills. All right. You're seeing a 5-year-old female brought in for fatigue and pallor. Otherwise, her development and growth have been normal. Mother reports that over the past year or so, she seems to have less energy, and compared to her peers, she looks pale. She also seems to be gaining weight in her trunk, even though she eats healthy food and her mom tries to keep her active. On exam, she looks normal. She has pale conjunctiva and splenomegaly to the pelvic brim. Lab confirms an anemia with schistocytes, and x-rays demonstrate osteopenia. This is most consistent with alpha manocytosis, Gaucher's, Hurler's, Niemann-Pick type A, or Sanfilippo. So this is Gaucher's. The anemia with splenomegaly and no other coarsening features is consistent with Gaucher's, and also the osteopenia is the other clue. Alpha manocytosis has hepatosplenomegaly, but also has mental retardation. Hurlers could have normal development, but growth is usually short. There's usually macrocephaly and coarsening of the facial features. Niemann-Pick A is severe and associated with mental retardation as well as hepatosplenomegaly. And then Sanfilippo's is characterized by loss of skills and regression and usually doesn't have anemia or osteopenia. Right, cystinosis is autosomal recessive. It's a defective transport of cysteine out of the lysosomes. So then it begins to crystallize within the lysosomes, and this causes cell damage, leading kidneys to fail, and then the cornea causes light sensitivity. So you end up with a renal Fanconi picture and failure to thrive, and you give them a medication that removes cysteine from the lysosomes. Metachromatic leukodystrophy is autosomal recessive. You're missing your aerosulfatase A, and then you get metachromatic deposits in the central and peripheral nervous systems and visceral organs. Onset of symptoms can be infantile to adult, and clinical features include optic atrophy, progressive neurologic problems with loss of skills, and psychiatric disturbances. Canavans is autosomal recessive, aspartyl acylase deficiency, and more common in the Ashkenazi population. When you look in the urine and plasma, you'll see an elevation of N-acetyl-aspartic acid, or NAA. These kids always have big heads, and you can see the growth chart here. The head circumference is way above the standard. Not only is their head big, but also the brain is big, and there's also evidence of demyelination. They can have hypotonia and loss of motor skills at 2 to 4 months, and then become very spastic, optic atrophy, and seizures. All right, parents who are new to your area bring their 4-year-old son to your office for evaluation of poor growth and developmental delays. They say he was growing well until about 2 years ago, but now his height has dropped off. He has never had any words, but did have about 20 signs. He's had multiple ear infections with PE tubes placed 3 times. His other developmental skills were on time, but in the past year or so, he stopped doing things he used to do, like go up and down stairs. He is no longer signing, and he's become more aggressive with his family and peers. You review his records and note that his height was at the 50th percentile at age 2, and now it's at the 10th percentile. Physical exam, the boy has dark and heavy eyebrows, full cheeks, and full lips, but no hepatosplenomegaly or joint problems. Condition that is most consistent with this child's presentation is glycogen storage disease type 1, Hunter syndrome, Hurler syndrome, eye cell disease, or Sanfilippo. And the answer is Sanfilippo. So this is unique among the MPSs in that you're not as coarse, you don't have a big liver, you don't have really the bone problems, but you're starting to lose skills and backtrack. Eye cell disease presents at birth with coarsening of facial features, dislocated hips, club feet and hernias, progressive contraction of the joints, and severe mental retardation. GSD type 1 should present with hypoglycemia. And Hunters or Hurlers both have the coarsening of features, and you would see an enlarged liver. All right, peroxisomal storage disorders. What are the peroxisomes? They're little organelles in all of our cells that help to break down compounds, and they have an impermeable membrane to keep their functions isolated. They are important in fatty acid beta oxidation and catalyzes the breakdown for very long-chain fatty acids, bile acids, branch-chain fatty acids, and econosides. They are also important in ether phospholipid biosynthesis, also known as plasmalogens, and they're an important part of brain development. Catalase, which is the degradation of hydrogen peroxide, where they get their name, peroxisomes, and then they're also important in some steps in cholesterol synthesis. So the one that you run into the most is the Zellweger spectrum disorders. And in this case, you don't make normal peroxisome. So anything that was supposed to happen in the peroxisome isn't going to work. So it's not a problem of any of those enzymes that are important in the peroxisome, but if the bag can't be put together, nothing that was supposed to be in the bag is going to work well. So you see absent or reduced function of all enzymes that go into the peroxisomes. They have characteristic facial features, a large anterior fontanelle, cataracts, a pigmented retinopathy, epiphyseal stippling, liver function abnormalities, and jaundice. This spectrum includes not only Zellweger syndrome, but also neonatal adrenal leukodystrophy and infantile Refsum's disease, and their progression in a spectrum of this disorder. Okay, so you're examining a 12-month-old male who has had a 2-month history of developmental regression. During his first 6 months, he met all motor, language, and social milestones. On physical exam, his growth parameters are normal, and except for poor eye contact and marked head lag, there is no organomegaly or other physical findings. The most appropriate diagnostic test is glucocerebrosidase, Fragile X, hexosaminidase A, MECP2 gene testing, or urine N-acetyl-aspartic acid. The hypoglycemia is setting in. All right, so the right answer here is hexosaminidase A. So knowing the disease and the enzyme, make yourself a little chart and table. So hexosaminidase A is Tay-Sachs. So remember, the kids with Tay-Sachs do well over that first 6 months or so and then start to become symptomatic. N-acetyl-aspartic acid looks for Canavans, and you would expect to have a big head. Glucocerebrosidase is Gaucher's disease, so you'd expect hepatosplenomegaly and anemias. MECP2 is the gene for Rett syndrome, and so you would expect that hand-wringing sign and acquired microcephaly. And Fragile X is generally delayed from birth, and there's no loss of skills, but slow progression and attainment of skills. All right, Smith-Lemli-Opitz is a problem of cholesterol biosynthesis. It is recessive and occurs in about 1 in 20 to 40,000 people. It's a deficiency in 7-dehydrocholesterol reductase, and it causes an increase in 7-dehydrocholesterol. Your cholesterol will then be low or normal. Remembering that cholesterol is important in embryogenesis, so this was actually the first metabolic condition that was defined also as a dysmorphic syndrome. So you can see craniofacial problems, small head, anteverted nares, ptosis, and cleft palate, tooth-3 syndactyly, hypospadias or ambiguous genitalia, and mental retardation. Treatment is with dietary cholesterol and bile acid supplements. May help with behaviors, but it's not been shown to change intellectual functioning. So again, here are the characteristic facial findings. Again, the anteverted nares, ptosis, can have a cleft palate, hypospadias or ambiguous genitalia. Purine disorders, Lesch-Nyhan, which always seems to be a favorite of test makers. It's deficiency of hypoxanthine guanine phosphoribosyltransferase transferase, also known as HGPRT. These people all have elevated uric acid. It is X-linked recessive, so you're going to see it in males and not females. May present at about 2 to 3 years of age with self-mutilation. They like to bite off their fingers and lips, and so people end up getting all their teeth pulled. There are developmental delays. They have renal stones and gout secondary to the increase in their uric acid production. I have not seen very many people with this condition, but people love it on exams because they bite themselves and self-mutilate. Copper metabolism problems include Menkes disease. So with Menkes, there's no copper uptake into the liver, and so there's a deficiency of copper and copper metabolites. These kids will have hypotonia. They will fail to make their milestones. It's also called Menkes kinky hair disease. So if you pull out a hair and look at it underneath the microscope, you'll see it kink and turn. They often have seizures, and again, this is an X-linked disorder, so males will be affected and women won't. The opposite problem is Wilson's disease. Now you're going to take up too much copper, and then you're going to have a buildup of copper in your liver and in your brain. This is an autosomal recessive condition. Clinical features are Kaiser-Fleischer rings that you can see on the iris, often picked up by your friendly ophthalmologist. May present as a psychiatric disorder and also with liver dysfunction. And so you're going to treat this by giving them agents that bind copper, like penicillamine. Congenital disorders of glycosylation can affect any organ system, and it's a defect in glycosylation of molecules via the endoplasmic reticulum. So it's important for targeting of molecules. So you're not getting the sugar groups onto all of the other compounds that you need so that they can be appropriately targeted and flagged. There are more than 12 forms. The most common is CDG1A, and is the classic form for this condition. They have cerebellar hypoplasia. They have a liver disease, inverted nipples, and abnormal fat pads, which you can see in here, in those areas. All right. So back to newborn screening. Every state does newborn screening. Every state is an independent entity, and so each state gets to pick independently what's on their state screen. So the types of things that are screened for are intoxication, so some of our amino acid disorders, or organic acidurias, and some of the urea cycle disorders are seen and picked up by newborn screening. Energy metabolism defects, such as fatty acid oxidation disorders. Things that are not identified on screening: complex molecule problems, glycogen metabolism problems, and mitochondrial defects. So the types of tests that we do on newborn screening include enzyme analysis, and those are primarily for galactosemia and biotinidase deficiency. Hemoglobinopathies are tested for with protein analysis. You can also see endocrine problems on there like CAH and hypothyroidism. And then we quantify amino acids and acylcarnitines for our inborn errors of metabolism. Many states are now testing also for cystic fibrosis. Stay tuned because we're also testing for SCID in some states. They've just now instituted, everybody needs a pulse ox before they go home to test for congenital heart disease. And variable in states and from hospital to hospital if you do newborn hearing screening. All right, so the enzymes that are tested are the GALT enzyme, galactose 1-phosphate uridyl transferase. Absence causes classic galactosemia. Biotinidase enzyme, the absence causes biotinidase deficiency. The results are based on fluorometric reading of the enzyme activity in red blood cells or serum. So if you have had a blood transfusion, it will affect what you get your reading on this particular test. Also, if you are working anywhere in Texas in this time of year, or like I was in Southern California and we shipped our stuff for the military back to Colorado, if your truck gets stuck in the desert for more than, 5 minutes, it's going to destroy all of your enzymes. So if you get multiple enzymes back that aren't working, you have to worry about that something else is going on rather than your patient has like 2 different enzyme problems. Think about sitting out in the heat and destroying your enzymes. Hemoglobinopathies, you're able to detect sickle cell variants and other variant hemoglobins on newborn screening. And it's based on the migration in gels for different proteins. And the follow-up depends on the different types of results that you get. And again, any blood transfusion is going to skew your results. Congenital hypothyroidism is one of 2 diseases that is absolutely screened for in all states, the other one being PKU. And they're going to measure the amount of TSH and or T4 in the blood. So know what your state does. And it's also dependent on the time of collection. Congenital adrenal hyperplasia measures the amount of 17-hydroxyprogesterone in the blood. Small infants or those that are premature will not make the same amounts of 17-hydroxyprogesterone, and so the results are weight and or age-based. Milder forms can be missed if you take the sample too early, and then confirmation is based on serum levels. Cystic fibrosis measures the amount of immunoreactive trypsinogen or IRT on a blood spot. and it's elevated in babies with CF. It's also elevated. It's an acute phase reactant, so if mom's had a very stressful labor and delivery with an emergent C-section, that may go up as well. If you have an elevated IRT, they'll run, in most states, go ahead and run common mutations on the blood spot. But still, the gold standard is a sweat chloride test. So now, if you're having a positive IRT, even if you don't have mutations found on your screening test, we will still bring you in and do a sweat chloride. Tandem mass spec gets you 25 to 30 disorders on one blood spot. Run time is about 1 to 2 minutes per specimen. It's a sensitive and specific test. Cost is about $10 per sample. Test for amino acids and acylcarnitines, and the interpretation is based on a pattern analysis. So you have a background amount, and then you can figure out how much of the compound you have there. So again, it's a quantitative test as opposed to the old-fashioned Guthrie, which was a qualitative test. So we can detect acylcarnitines, and that will look at fatty acid oxidation disorders in our organic acidurias. And you look at elevations of various odd-chain acylcarnitines that reflect the buildup of the keto acids. For the fatty acid oxidations, they're even-chained. Amino acids will get you your amino acidopathies, but it will also help you pick up urea cycle defects with your arginine, citrulline, arginosuccinic acid. Things you need to know. Be familiar with the presentations for galactosemia, MSUD, MCAD, GSDs, MPSs, PKU, homocysteine, urea cycle defects, and Zellweger spectrum. Associations: hexoaminidase A, Tay-Sachs. Galactose uridyltransferase, or GALT, classic galactosemia. 7-DHC, or 7-dehydrocholesterol, is Smith-Lemli-Opitz. Acid maltase is Pompey's. Pompey's is also GSD type 2. Clues that it may be metabolic: anion gap metabolic acidosis, low glucose, with ketones, without ketones, with or without hepatomegaly. Know what goes into each of those boxes. Respiratory alkalosis: look at your ammonia. Is there loss of skills or regression? And do you have big organs? This is my other daughter demonstrating hypoglycemia. You guys stayed awake. Good job.